Welcome to the Shockwave Therapy Podcast. My name is James Woolwich, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Today we are joined by Dr Tomás Nedelka. He's a consultant neurologist at Charles University in Prague and in private practice. He's the first vice president of the International Society of Medical Shockwave Treatment. He has a special interest in the use of shockwave therapy for chronic low back pain and has published a number of articles on the subject. The one in particular we'll be talking about today is titled The Mechanotransduction Effect of Shockwaves in the Treatment of Lumbar Facet Joint Pain. This was a comparative effectiveness evaluation of shockwave therapy, steroid injections and radiofrequency medial branch neurotomy. It was an excellent trial which I think everyone will find of interest today who treats low back pain, particularly chronic low back pain. So I'd like to welcome Tomás to the podcast today. Thank you. So thank you, Tomás, for joining us this evening. I know we've had some difficulty joining together on this, but I'm looking forward to your insights in particular on low back pain. Could you just give us for the people out there that don't know you in particular, can you just give us a little bit of how what your work involves in the Czech Republic and your position as a doctor there?
Yeah, thank you, James, for your kind invitation, and I hope that the themes we are going to speak about today evening will be maybe refreshing and will be a new fresh breeze regarding the use of the shockwave therapy.
Sure.
Basically, what's sometimes difference between patients that I come from the completely different brand and the musculoskeletal specialists. Basically, I'm a neurologist, and I got in touch with the shockwave therapy back in 2006 when we bought the first machine, which was radial.
Right.
And then we found that it's really effective in some diagnoses, but in another, the efficacy is somehow lacking. So that's why we bought a new focus device back in 2010, or I don't remember quite well. But since that time, we have a lot of experiences about the use of the focus devices. And in our country, the neurologists are also responsible for treating different types of pain conditions.
Right.
Even low back pain, neck pain, failed back syndromes, and so on. In our country, that's not a domain of neurosurgeons or rheumatologists, but neurologists do so. And this was also my point of interest back in the medical faculty and then in the university, that I oriented my research and my practical knowledge on treating of those painful conditions of spine.
Sure. Okay, that's interesting to know, because neurologists in other countries, they probably wouldn't get involved in low back pain. So your details came to light, I think, because of a colleague, Paul Hobra, did a nice interview with you about a year ago. And so I looked into your research paper you did in 2014, which I thought was really fantastic. Could you just give a quick summary of what that research was looking at?
Definitely. It was a relatively large study, which was comparing the efficacy of radial shockwave therapy to steroid injections and radiofrequency treatment, which is considered to be a gold standard in treatment of facet joint pain in our country and worldwide, with the highest level of evidence. But because we are practicing all of those methods, including radiofrequency treatment, and we have seen that something is happening And there are some serious adverse effects in those invasional methods. Complications, including bleeding, for example, into the periarticular and into the soft tissues of spine. And I have also seen some pyogenic, like let's say inflammatory radiofrequency treatment. So we were looking for a method which will be absolutely safe. That's why we have focused on the shockwave therapy, because we had a good experiences in tendinopathies and calcifying tendinopathies. So I asked myself, why not to use it on the facet joints?
Right. And the outcomes were very impressive, weren't they? They actually were better than steroid, and just a tiny little bit behind the radio frequency.
Yes.
Can I ask you, what do you think the mechanisms of action are?
I think that the mechanisms are now, when I see the results, and we will talk about it slightly later, because we did another study which is now still in process, and we are finishing that. We've got a very nice MRI evaluation.
Right.
And I think that there are 2 points. First of all, we have to speak about the joint inflammation.
Mm-hmm.
We speak about bone marrow edema, which is usually in affected facet joint. Marrow changes or articular process edema in the patients suffering from this kind of lower back pain, which is highly specific. And we have found that after the shockwave therapy, doesn't matter if focus, because we have MRI evidence of focal therapy. But I think that even in radial treatment, we are influencing both capsular joint pain as well as edema, or the pain which is outcoming from that.
Oh, okay. We just to summarise, because we break up a bit of signal there. So you think that the radial or focus shockwave seems to have an influence on bone marrow edema within the facet joint and general inflammatory changes around the facet joint?
Yeah.
Oh, okay. Do you think it has any role in from a denervation point of view, in terms of how it might affect the neurology of the area?
That's of course the third player, but it's very hard to investigate the overall functions of the nerves which support or which innervate the area of facet joint. So it's very hard to provide evidence that single level application of shockwave therapy had any effect on, for example, EMG or electrophysiology or the nerve conductions. But I think that it's another part of the effect of shockwave therapy. But usually the pain, just the sole pain effect of shockwave therapy is short term, but we gain much better long-term results than just the suppression of the nerve and sensory nerve fibers.
Was I right in saying that your follow-up data went for as long as 12 months? Was that right?
Yeah, it was 1 year, 12 months in both of the studies of radial as well as the focus device.
Right. That's the one. I think we lost a bit of reception there as well. So the current study that you've done is on focus shockwave for the same condition, but results are pending for that. You're collating the results now, aren't you?
Yeah.
But I won't ask you to give too much away, so we'll move on from that. But so when the thing that people are gonna ask, I think, is I think you used ultrasound guided imaging to help with where you place the applicator on the lumbar spine. for those of us that don't have that sort of guidance, is there any advice you can give to people on patient positioning? Were they always in prone position, and what sort of angle of attack did you use, or did you use landmarks to try and achieve where you were going to be providing the energy?
That's the reason why I use the ultrasound focusing, because for example, when we have obese patients with higher body mass index, we are in a higher depth of application. So that's why I'm looking onto the ultrasound screen, and I'm putting the landmarks on the skin, the points just above the area. So I use, when we are speaking about the angle of attack, I use 30 degrees of angle from lateral part of affected facet joint. And it's necessary to keep in mind that we are able to use the landmark on, let's say, more skinny people. But when there's more fat tissue, it's very hard to find the landmark. So that's the highest advantage and the biggest advantage of ultrasound imaging, that we can look at the deeper structures. But generally speaking, we can combine the even with the clinical focusing. When we have, because in our pain clinic, we run the rehabilitation and pain and neurology department, we are usually doing the local anesthesia, medial branch blocks, to find if it's temporarily effective on the pain sensation. So when we are successful in the let's say facet joint or medial branch block, we have a patient with the facet joint pain. It's very hard to estimate that the patient is having this kind of pain just from the clinical examination, according to the data which is published as well. But if the patient responds to the LA block, or if he's having the typical, let's say, extensional pain, which is which is purely axial or slightly paraaxial, we have a typical patient with facet joint pain. And then we use the combination of guided and clinical focusing. So the angle of attack is around 30 degrees from the lateral part. So it's the applicator is slightly inclined, and then it's necessary also to remind that we have to apply the shockwave therapy in multiple levels, because the innervation of the facet joint with possible source of nerve irritation, and we are speaking about the peripheral nerve dysfunction or the medial branch irritation. The facet joints are innervated in two. So it's necessary, from my point of view, it's necessary to apply it at least on two segments of the lower back. So if we have, for example, L4-5 irritation, I usually use L3-4, L4-5, but also L5-S1 multiple level application, because it's very hard to estimate which level exactly is the affected one. We can see bias of the facet joint on MRI, rarely on ultrasound, but usually we perform the MRI in our patients. But the facet joint pain is the clinical diagnosis.
Okay. And what
it's necessary to apply multiple levels.
And could I ask, I think you use a Storz machine, don't you? Storz radial machine. And what applicator do you what applicator do you use, Thomas, for this?
We use the Short's dual system, which has both focus and radial option.
Yes.
And when we are purely speaking about a radial applicator, we use the deep type. I'm not sure what's the name of it, but the type of the applicator for the deeper structures.
So is it got a gold? Is it a gold tip conical shape?
The gold one or the titanium one? Yeah, the gold one.
That's the one. Okay, fine.
That's it. Yeah.
And what sort of, have you come to a conclusion, do you think, about hertz and about bar pressure?
We use, you mean the frequency?
Yes.
We usually use the lower frequencies, from 6 to 8, maximum 6 to 10 hertz, but we are usually not working at the time stress. So from our point of view, the lower frequencies were had better results. I don't know the reason for that, but we usually use frequency settings around 6 to 8 hertz, not more.
Okay.
And when we speak about the pressure of the radial pressure waves or radial shock waves, we usually use 3.5 and more bars. So 3.5 to 4.5. So we are speaking about higher levels of energy which is delivered.
And if you're talking about three levels that you are affecting the treatment, do you say do 1,000 impulses for each level? Is there a number that you try and fix to?
Yeah, usually 1,000 at least. So it's the minimum dose.
Okay.
But for one segment, we usually use 1,000, 1,200.
And do you see these patients for 5 sessions over 5 weeks, or how do you usually run that clinic?
Yeah, definitely 5 sessions, and the intervals are weekly. So 5 sessions in 5 weeks. That's
okay,
true.
Right. And so if we go back to the idea, because I remember when you spoke with Paul Hobro that we were reasonably excited. Now you were using some focused devices for this, and you have some trials pending. But what is your initial thoughts on what your if you were in clinic tomorrow and you had patients with facet pain in this scenario, do you tend to find that you are getting slightly better results with focused, or combination of both, or what?
Well, there was one reason which is very important in this kind of treatment, and that reason was that we didn't succeed with influencing the facet joint pain with radial device in obese patients, more with the BMI higher than 28. So not so obese, but with higher BMI.
Right.
And when we consider how many patients suffering from that type of pain has higher BMI than 28, we definitely see that there's a need for something more effective, because the basics and the physical knowledge about the focused shockwave therapy is completely different from the radial one, which is dispersed in the superficial tissues.
Yes.
However, the focused therapy is much more efficient into the deeper structures, and also it's better when we want to influence the bone marrow edema.
Okay. Right. So you're using that in those patients and getting reasonable results, so you think?
Currently, we use the focal therapy as our first treatment option because in the pending study, we gained much better overall results when we compared it. We didn't compare it to the another options of treatment, but
Sure.
We compared it to the sham device, which was blinded. So there was a fact that this kind of device, or this kind of cushion which was placed between patient and applicator, was not delivering the shock waves into his body.
Okay.
And thus we used very nice results, and we use it as our prior therapy with better results compared to even to radial device, which also succeeded.
Okay. Oh, that's really interesting. You had a sham focus device.
Yeah. Well, it's just a small, let's say, air-filled pillow or a small cushion, some small membrane, which is put between the patient and the active device. But we know that the air is not conducting the shock waves at all.
Right.
So that's why we use it. Yeah.
Oh, okay. I like that. Okay.
A very smart system to use. Let's say, even in your or in the physio's offices and so on, you can use your own clinical trials to see if this kind of therapy is helpful or not. When you just use a kind of this kind of sham device or this kind of sham applicator insert, when you just put a small amount of air into the membrane between the body of the patient and the application.
Okay. So can I ask you something I think that's going to be quite important, because there's lots of us using Shockwave that don't have access to ultrasound. If we go back to your idea of imaging to almost guarantee where your applicator is going to be placed, would you say that it's absolutely necessary to use ultrasound guidance in treating low back pain, or would you say that it still is going to benefit patients to some degree?
Well, if I'm speaking about myself, with access to 3 different ultrasound machines which are present in our ward, I will definitely, and I'm doing the therapy with it. But I can imagine that in some sort of patient, excluding those without any landmarks, palpable, visible, or something, that let's say in 50% of patients, I will be in the area of the facet joint when I use appropriate angle of the applicator, and also when I search for the typical kind of clinical feedback, like
yes,
the pain which is present in the reclination, which is similar when we apply the shock waves into the area. So the elicited pain is usually same as the patient feels in the types of movement of his lower back. So when I find this in my patient, I'm in the vicinity of the joint.
Okay, fine. Because at the moment, I think when I've talked to a few people that are using particularly a focus device like I do for this, the reproduction of their pain is pretty impressive. That they actually does seem to give them what they suffer. And of course, without an ultrasound guidance, that is as good as we can get to assuming that we're near their facet joint.
Yeah. We've got the same results when we use basic settings and also good or appropriate applicator settings, as well as in our patients. But we use also the clinical guidance or the ultrasound and the clinical guidance, also because we usually use the patient's data for the study reasons. So that's why we are bettering our diagnostic options and, let's say, more scientific principles than just the pure clinical focusing on the pain, which is elicited by the application.
Okay, great. Well, that's really interesting. Can I just ask just a separate question, which is about treating the other areas of the spine? And I know that the contraindications that are put up by ISMST are very minimal now, but I do get asked a few questions about treating the neck area. and I just wanted to ask your opinion as to the safety of treating the neck on areas that are a little bit more vulnerable, particularly with calcification of the vertebral arteries and so forth. What's your experience of treating neck pain, and do you have any concerns about safety?
Yes, we have some data about the neck pain from the research of our specialists, because we know that a couple of users of shockwaves did it in the myofascial pain syndrome of cervical spine. There's a couple of studies which use it also on the trigger points and so on, and they didn't observe any effects. When we speak about the actual or the application in the axis of the cervical spine, or the application around the cervical facet joint, which is sometimes the issue of the pain in some percentage of our patients. We have conducted the vertebral artery scanning using the ultrasound technique of Doppler imaging, and we didn't find any kind of disturbances. I will be careful around the vertebral loop, just below the skull. But in the usual segments like C3 and below, I think that because the vertebral arteries are covered from the bony structures of the spinal canal. So that's why when we use the low to medium level and energy setup, we are on the safe side.
Are you talking about radial low to medium energy, or are you talking about both devices that you need?
When I'm speaking about radial, I will recommend to use maximum 2.5 bars. When I use the focal device, I will prefer to use levels in the lower energetic setup, like 0.12 millijoules per square millimeter and below.
Okay. And did you? Sorry, it just broke up there. On the radial, you would stick between 2 and 5 bar. Is that right?
No. 2 and 2.5.
So I see.
Not more than 2.5.
Okay, fine. So 2.5 bar for a radial device, and 0.12 for focus device.
Yes.
Okay, and trying not to go probably up into C1, C2.
Yeah, definitely.
Okay, well that's good to know. All right. Thank you very much for that. That's been really interesting for those of us that treat lots of spinal pain. So I'd like to thank you for your time, and I think the only thing I may contact you again. It might be just. Is there anything where you've done any videos, Thomas, about how you apply the applicator to the lumbar spine, anything like that you've ever done before?
Thank you for inviting me into your podcast, James. And I'm really lucky, and it's very nice of you that you have invited me, because it's a good opportunity to share my knowledge about the treatment of lower back. So thanks again. Regarding your questions about your video, I've got some of them, but they are of poor quality now. So we are thinking about it for a couple of months. We didn't have a need, because we usually we are not using so much this kind of let's say more commercial or video applications, even from the ethical results as well.
Sure.
We are oriented mainly on to our clinical practice, but in our clinical results and results which are published in our studies. However, if you are interested, we may record something in, let's say, following months. Now we are preparing the new ISMST Congress in Vienna, so we are in the process of preparation. Then I will be rolling out the Congress in Prague in 2021.
Okay.
So everybody will be invited in June 2021 to Prague. There will be very nice session, and also there will be very nice ultrasound diagnostic session about the usage of musculoskeletal ultrasound in practitioners and physicians, and also in physiotherapists. So
Sure.
there will be 2 sessions about the use even of the shockwave or radial pressure wave, and also of the diagnostic ultrasound in our Prague Congress. So that's the maybe a kind of surprise for the ISMST visitors in Prague.
Will any of your results be? Are you going to be talking about any of this in Austria this year at the ISMST?
Yeah, I will speak about it in my session regarding the new perspectives of shockwave therapy in the ICC course, and I will speak about it also in our neurology session when I have my opening talk there.
Okay, well, I plan to be there, so I'll thank you then for doing this podcast for me, Thomas.
Great, looking forward to meet you there.
Super, thank you very much for your time, and goodbye.
Bye-bye.
Thanks a lot, bye-bye.